you, Chair, dear audience. Good day, everybody. My name is Bertalan Tordai, and I would like to show you the 6 months progress of my research on the effect of migration on healthcare. I'm a physician and also a first-year PhD student here at the Center for Translational Medicine. My team and I have a clear vision, which is to assist migrants and immigrants in integrating successfully in the host society. We would like to achieve that by identifying effective interventions for improving the health outcomes of migrants and immigrants. Right now we have 2 ongoing projects. The first will aim this topic on a broad spectrum, a global scale, with the help of a systematic review and meta-analysis. And the second one will be a little bit narrow one, aiming only on the EU with the help of a Eurostat analysis. The first project is on investigating the cardiovascular risks of immigrants in comparison with the host population. Immigration is a specific phenomenon. In 2020, an estimated estimated 218 million immigrants arrived into the developed countries. While nowadays much focus on asylum seekers and refugees, the already settled down population, the first generation immigrants, pose a specific challenge to the healthcare system. It is an already known fact that the prevalence of the cardiovascular risk is currently declining in the host countries, with a decrease of by 57% in the EU from CVDs, but it still accounts for the 11% of the total healthcare expenditure of the EU. Meanwhile, it is not known that this influx of immigrants impacts this declining trend of cardiovascular risks or how these factors vary among the first-generation immigrants. After we have took a deeper look into this topic, we have chosen selective preventive strategy, which aims to a certain population and a certain risk or group of risks from our point of view, the first generation already settled down immigrants and the main modifiable atherosclerotic cardiovascular risk factors, which are high blood pressure, obesity, diabetes, smoking, and high cholesterol, according to the European Societies of Cardiology's guideline from 2021. Our aim is to identify the main modifiable atherosclerotic cardiovascular risk factors among immigrants versus host population. To meet our goal, we have posed the following clinical question. What are the levels of the main modifiable atherosclerotic cardiovascular risk factors among immigrants compared to the host population? We have outlined a PECO to answer this question, where the population will be the adults in a country with relevant immigration. The exposure will be the immigration itself. We will compare these these immigrants to the host population, and we will look for the main modifiable atherosclerotic cardiovascular risk factors I have mentioned earlier as outcomes. We hypothesized that the main modifiable cardiovascular risk factors differ between immigrants and the host population. If our hypothesis proves to be valid, we can directly transfer these results to the sake of society by supporting the development of effective and efficient cardiovascular preventive strategies. We have done our search in November 2024 with 2 domains, one for the population, one for the outcomes, in 3 databases, and we have got almost 20,000 hits. After the selection protocol, we have shrunken it down to 619 articles with missing 74. So right now we are at this phase. Data extraction have just recently started. We are drafting the data extraction sheet, and we are looking for the missing 74 texts also. The second project is on investigating the prevalence of the cardiovascular risk factors among immigrants in the European Union with the help of a Eurostat analysis. Eurostat is the statistical office of the European Union with over 2,000 statistical tables available and publicly accessible and regularly updated by the help of surveys, national statistical institutes, and administrative sources. Eurostat provides the data as macro data and micro data. Macro data shows country-level information that allows us to EU-wide analysis, and microdata shows us individual-level information. We would like to use these data for this research. Our research is based on 3 seemingly independent facts. The first is that between 1995 and 2020, more than 11 million deaths from cardiovascular diseases in Europe are avoidable. The second is that by 2022, more than 5% of the EU population consisted of non-EU citizens. That amounts 24 million people. And the third is that significant association is between socioeconomic factors like age, education, income, and gender, and cardiovascular risk factors. So these seemingly independent facts are connected by the trend of the prevalence of the cardiovascular risk factors, which are declining in the developed countries while elevating in the developing ones where most of the immigrants come from. Meanwhile, the prevalence of cardiovascular risk factors also vary among the immigrants with different origins in the EU countries. Therefore, our aim is to analyze these cardiovascular risk factors among immigrants in comparison with the host country residents and EU averages, and also adjust it for socioeconomic factors. So, therefore, we have posed the following clinical question: how do cardiovascular risk factors and major cardiovascular events among EU immigrants differ from those in the host population, considering the influence of education, income, age, and gender? To answer this question, we will use a PO framework where the population will be the EU citizens, EU country population aged over 15. The exposure will be the immigration, and we will look for the same outcomes as in the first project. The main modifiable atherosclerotic cardiovascular risk factors, mostly high blood pressure, high cholesterol, diabetes, obesity, and smoking. We hypothesized that the prevalence of cardiovascular risk factors and major cardiovascular events is higher among immigrants than in the host population, with socioeconomic factors playing a significant role. If it is true, then we can directly transfer it to the clinical practice by supporting specific preventive measures with the simplest and financially advantageous way possible. So as a summary, we have 2 ongoing projects at the moment. Both aims the same topic, but the first will be a global scale, and the second will aim it only to the EU, and both are planned to be submitted in the autumn of 2025. And I would like to close my presentation from a quotation from Confucius as referring to my number of articles. It does not matter how slowly you go, so long as you do not stop. Thank you for your attention.
Any questions? The background.
Okay, so full disclosure, I'm one of your co-investigators, and having gone through more than 70% of your final pool of articles, a genuine concern has risen. Over the years, countries' limits have modified, and seems they still continue to do so. How would you tackle this problem?
And that's an interesting question. Thanks for it. It's really not one question, it only disguised as one. So first, geographical limitations or borders does not matter. What matters is the time, so the length of time, and so that means, so referring first of that, the length of time, these changes occurs years, decades. So I think we should set a limit or borderline at some time, at some date, and this should be around the dissolution of the Soviet Union. So this is the first one, and the second one is that we have to separate the, let's say, peaceful immigration and the events which connects to specific events like catastrophic events, Holocaust or Chernobyl. We have a couple of articles about both of these topics. So these must be separately discussed. So yeah, this is my first thought.
Thanks. Makes sense. And actually, you disclosed 2 confounding factors. Yeah. Thank you.
Thanks.
I would like to also have a question related to your second project. So the age that you would like to include the participants were a bit surprised for me. So can you explain why did you include persons over the age of 15? Yeah,
because in Hungary we use so working age is over 18 years old, but EU considers general working age over 50 years old, so restricts under this age the working force. It is allowed. Some kind of jobs are allowed under 15 years old, like education type or so physically and other occupational health risk-free jobs are allowed, but mostly the over 15 years old population is the working age. And that's how Eurostat divides the population.
Okay, thank you.
Congrats on your interesting presentation. My question is that when you're comparing the data of host versus immigrant, should their ethnicity be taken into consideration? Because I don't think I saw that on the slides as a relevant factor.
It will be. So we will subgroup them. We will do subgrouping. We will use the UN if we have specific data from regarding the origin, so country or ethnicity data, we will use that one. If we do not have, then we will go wider, so use wider regions like the UN migration regions.
Thank you very much.
Thank you for your lovely presentation. It seems like that you have a lot of articles, a lot of data. So do you plan to do subgrouping of sometimes? Can you do some subgrouping?
I have mentioned the geographical one, but obviously the risk factors will be discussed differently. So we would like to pull these data together. So the five risk factors and then subgrouping by risk factor.
Thank you.